Good afternoon, everyone. Welcome to this sixth webinar about patient-reported outcomes. I would like to inform you that this session is being recorded, and the slides will become available after this session. Just for the people who are joining us for the first time, I hope you can all hear us well, so please let us know if you can hear us using the voting tool. We disabled your microphones and cameras, but you can talk with us and share your questions in the chat box. So let's just do a test. Can everybody hear us well? Can you please vote or comment in the chat box? I see a few people voting. Okay, so I guess you can all hear us. If you have any technical issues, please contact our technical support desk and they will be able to help you out. So our guest speaker of today is Sheila Garland, and she is a clinical psychologist and an assistant professor of psychology and oncology at the Memorial University. So we are very happy that she's with us today. She has a lot of experience in patient-oriented research, so I think we can learn a lot from her. So I guess that's it for me, and I will go on with Sheila Garland.
Okay, afternoon everybody. So this is pretty informal. If you have any questions, please indicate them in the chat box and I will make sure to incorporate them into the presentation today. So I have 5 general learning objectives. First of all, I want to make sure that everybody is on the same page when we're talking about what patient-reported outcome measures are, and specifically also what they're used for. But I think it's important as you're thinking about patient-oriented research to discuss how to decide which would be the best patient-reported outcome measure to choose. I'm going to go through some examples of various patient-reported outcome measures, some that are more generic, some that are specific to particular populations or health conditions, and I'll review some of the strengths and weaknesses of each of those. And then I'll generally talk about how to evaluate whether or not a patient-reported outcome measure is quality. And then I'm going to go through some examples of where you might find a patient-reported outcome measure to include in your research. All right, so to start off with, you can generally think of patient-reported outcomes as outcomes that matter to the patients themselves. So these are really outcomes that are only known to the patient, and so we're using these outcome measures to measure these patient outcomes. They are all based on self-assessment, so that means that the patients themselves are rating or giving us information about their particular outcomes that are of importance to them. And this is any aspect of the patient's health status, and it is noted that these are coming again from the individual themselves without any sort of interpretation by the individual's physician or anyone else that might be in their healthcare team. Now, I wanted to just divert quickly to noting the difference between a PROM, which is a patient-reported outcome measure, and a PROM. So a PROM just refers to patient-reported experience measures, and these are more things about their experience of accessing care. So that might be, how easily they're able to coordinate with this care, what kind of emotional support they're provided, what kind of informational support they're provided. And again, this provides information from the patient's perspective without any kind of interpretation. We'll be focusing more today on the patient-reported outcome measures. So first of all, how to decide what type of PROM to use. And I think that this really needs to start early in the research process because we need to identify the outcomes that are important to the individuals in the population of interest that we're studying. So this might be things like survival. It might be things like symptoms, or it might be generally something more related to quality of life. The important aspect here is that input from patients at this point is necessary in order to accurately identify what these outcomes of interest should be. And so that's when I say, this should be starting early in the research process. You should be communicating with patients to identify what sorts of measures you'd want to choose. There should also be some evidence to support that the selection of the outcomes that you're using are actually meeting the criteria of what would be termed clinically meaningful, also patient-centered, and also relevant to decision makers. You can find this information in meetings with the individuals themselves. Maybe there's already published surveys that talk to this, or other published literature that might be relevant to the question of interest. And we'll go through maybe some aspects of these that you'll be able to find. So generally here, general patient-reported outcome measures are designed to measure very broad aspects of health and are suitable for a wide range of patient groups and the general population. I'm going to take you through an example of one called the SF36. But before I do that, I want to just talk specifically about advantages of generic PROMs and disadvantages of generic PROMs. So one of the main advantages is that they're suitable for use across a broad range of health problems. So that's a good thing if you're looking at more population-based samples. They can also be used for comparisons between treatments for different patient groups to assess comparative effectiveness. So if you're looking at patients with heart disease in one sample and you're wanting to compare them to patients with diabetes, and you use a general patient-reported outcome measure, you're able to do that. But they can also be used with healthy populations to generate normative data that can be used to compare patient groups. So this might be something like you want to compare your sample of patients with high blood pressure to the general population. So a generic PROM would allow you to do that. And they also have the potential to capture the influence of comorbidity on health, as well as any positive or negative effects of an intervention, should that be part of your research. So, with all of the advantages, there's also the disadvantages, which means that, some level of detail may have to be sacrificed, in terms of getting specific information about that disease population when applied to the more general population at large. And they may be potentially less responsive to clinically important changes in health. So an example of the SF36, these are just questions here from the survey itself. And so it would be, for each of the following questions, please mark an X in the one box that best describes your answer. So, how would you describe your health? And then they would rate on a scale of excellent to poor. And then compared to 1 year ago, how would you rate your health in general now? Much better or much worse? So the SF36 is probably one of the most widely used general quality of life measures. And you can Google that. You'll come up with a lot of background information on that. There's also disease-specific patient-reported outcome measures, and these are designed to identify specific symptoms and their impact on the function of those specific conditions. So I'm going to go through an example of the functional assessment of cancer treatment general scale, and that's called the FACT-G. But generally, these disease-specific PROMs have advantages in that they are clinically relevant to the population that you're working with because they've been developed specifically to be used for that population. They should also be responsive to clinically important changes in health that result from any intervention. And they do not contain any excessive information or anything that is not relevant to that particular disease. So because it's relevant, the acceptability and the face validity of these measures is likely to be very high because the patients will feel like, okay, yes, I can relate to these questions. They're important for me, therefore I'm going to answer them. There are some disadvantages though. So if we're looking at patients with gastric cancer, we're not really able, and we're using the FACT-G, we're not able to compare those individuals to the general population as we would with a more general PROM like the SF36. We're not also able to make any comparisons across treatments for different diseases. So it might limit the application of these for economic evaluations. and the restricted focus of the disease-specific instruments might make it less likely that we're able to detect side effects or something that is not known as an effect of the treatment. So this is an example of the FACT-G, and you can see that there are some specific there's general questions, but they're related to cancer, right? So I have a lack of energy, I have nausea, I have pain, I'm bothered by the side effects of treatment, I feel ill, that kind of thing. There's actually 4 domains here to the FACT-G, which is physical, social, family, functional, and emotional as well. So we've talked about general, we've talked about condition-specific ones, but this is also population-specific measures of patient-reported outcomes. So these are appropriate to particular demographic groups, such as maybe children or elderly people. And so an example of this is the CHIP-CE, which I'll show you on the next page. So some advantages of population-specific patient-reported outcome measures is that the content may be more relevant to the group in question. So if you're looking at school performance in young children, you'd want to use a population-specific PROM. They can also be more tailored to the population that you're working with, and that's where the CHIP-CE also comes into play. We can use cartoon illustrations to convey instructions rather than text. We can make these measures more accessible to certain populations than others. And this may make them more sensitive to systematic differences between groups. There are some disadvantages, and a lot of them are similar to those of the disease-specific measures in that you can't make comparisons with the general population, and it's also difficult to compare the efficacy of particular treatments across population groups. So this is an example of the CHIP-CE. So again, made for children. So in the past 4 weeks, how often did you feel really worried, right? So you've got never, and you've got a visual picture here, and you've got a small circle up to always big circle with a visual picture here of somebody who might feel really worried. Then there's also the dimension-specific PROMs. And so these would assess one particular aspect of health status. And these are aspects that are most commonly identified as being relevant to patient-reported outcomes. So in your discussion with the patient partners or your individual groups that you're going to be working with, they can help to identify if there are any specific dimensions that would be particularly important to them. And these, again, cross a wide variety of areas. So it could be physical function if you're dealing with, any population. Maybe it is a population with multiple sclerosis. So maybe they're most most interested in detecting differences in mobility or dexterity, range of motion, physical activity, or activities of daily living. But again, I work with a cancer population most often, so I'm dealing a lot with symptoms. So that might be something like pain, nausea, appetite, could be energy, vitality, or fatigue. My specialization is I work with sleep. So we can also measure psychological well-being if that's a particular concern. So that could be anxiety, depression, coping, or sense of control, among other aspects of psychological well-being. But it could also be personal constructs. So for example, in a sample of women with breast cancer, it might be more kind of satisfaction with body appearance. Maybe it's stigma for certain other illnesses, or maybe it's in terminally ill patients. Maybe the biggest thing that would be important to them would be kind of spirituality or kind of more existential issues. But again, these are things that you would find out in talking to the group that you're going to be working with to find out exactly what is the most important thing for them to be involved with. So social well-being might be, family and intimate relationships, or social contact or integration. This might be relevant for individuals with disabilities. Leisure activities. Cognitive functioning might also be important. Let's say if it's a patient population who has acquired brain injuries, they might be interested in things like concentration, memory, confusion, or ability to communicate. Or maybe it's the impact of that particular condition on what they're able to do during the day. So that might be some role activities. Are they able to be employed? Are they able to manage their household? Or, do they have significant financial concerns as a result of their particular situation? And lastly, how satisfied are they with their care? This kind of crosses over into more of like the patient-reported experience measures, but that's a little bit of an overlap right there. So there are some advantages of these dimension-specific PROMs. This is that they really get in there and they provide a more detailed assessment than you can even hope to get with any of the disease-specific or the generic instruments. Many of the instruments include measures of physical functioning as well as psychological well-being. So it's not like you have to really kind of choose one or the other. There are some that include both, so that there's a wide range of data available for comparing and interpreting results. However, the disadvantages include that a lot of these measures were developed with the primary objective of diagnosis or a needs assessment. So, some of the measures for depression specifically were to make clinical diagnosis possible or easier, and maybe that's not the most important thing that would be relevant to your patient groups. So before you use any such instruments, you need to evaluate their applications or their appropriateness as outcome measures. And we'll talk about how to do that as well. This is an example of a very commonly used measure of anxiety and depression. This is the HADS, or the Hospital Anxiety and Depression Scale. So you can see that here along the side, any of the numbers, the values that are under column D would be under the depression part of the HADS, and any that are under the column that has the A, that would be under the anxiety column. So, I feel tense or wound up, and patients are reporting here 3 most of the time, 2 a lot of the time, from time to time, or occasionally, or not at all. So this is, again, an example. What the examples that I'm providing here of the measures, these are ones that you should be able to get access to and have already been widely validated. This is also a specific measure that is part of the functional assessment of chronic illness treatment. That's the FACIT. If you were to Google FACIT, F-A-C-I-T, that's in chronic disease, cancer specifically, you'll see a number of various patient-reported outcomes that are available there. This one is specific to gastric cancer. So you can see that these concerns would be relevant to patients who have had diagnosis of cancer treatment of the stomach, or the diagnosis and or treatment of cancer of the stomach. So, I have loss of appetite, I'm bothered by reflux or heartburn, I'm able to eat the foods that I like. This one is reverse scored, so, whereas somebody might be very much bothered by reflux or heartburn, they might say, no, not at all, I'm not able to eat the foods that I like. And again, this would be a measure that has quite a bit of face validity or relevance because it has been designed to be specific to individuals who have gastric cancer and are concerned about these physical and emotional symptoms. There's also individualized PROMs, and I haven't seen these be used as much as maybe they should, because I think that in the vein of patient-reported outcome measures, they definitely have some strengths. So basically, these instruments allow respondents to actually select the content of their own items and rate the importance of those individual items. So versus the other ones, all of the content has already been decided. And even if those were decided with the input of patients, it may not be relevant to the individual. So we're looking at group problems versus individual problems. So these individual PROMs, they can take in the concerns of the individual patients rather than impose any external standards that may be less relevant. And so they do have high content validity because the individuals are actually naming their specific concerns. So with these ones, though, you may have to administer them by interview. in order to produce the response rates that are similar to those for standardized instruments, just in case there's any questions or confusion, because there is a little bit more room here for interpretation. And so if you're thinking about doing this with a large sample size, this may have some implications for feasibility when compared to standardized instruments that you might be able to send to a large group of individuals and have returned to you quite easily. So this would be an example of one is the patient-generated index. So the patients would identify here up to five areas that are the most important to them. So this might be things like, continuing to be able to work, spending time with my family, controlling my pain, getting good sleep, and being able to eat the foods that I like. Those might be 5 examples. And then in step 2, they score how badly were they affected over the past month. So if it was good sleep, was it that's important to you, but over the last month, did you have any trouble with that area? Is it exactly how you'd like it to be, or maybe it's the worst you could imagine? So they identify their important areas, then they score how they've been in those important areas over the last month. And then this is where it gets a little bit trickier, and why it's nice to have these administered via interview, is because then the patient is instructed to imagine that of any of these areas in their life that they could improve, if they have 14 imaginary points to spend to show which areas you would like to see improve the most, then they would identify, like, okay, so yeah, maybe my sleep's important, but maybe spending my time with my family is much more important, even though maybe spending my time with my family I'm not satisfied with. So I want to spend the majority of my points here on spending time with my family, even though maybe sleep is still a concern. I'm just not really wanting to put my resources there. And then these are any other areas affected by health problems, and then any other areas that are not related to health. So maybe it just even gives them other areas here that they can decide where they want to focus on. So you can see how this might be very applicable and really get the individual on board with what areas of their life are most important, and then how much emphasis or work are they willing to do in order to address those. So I wanted to just talk a little bit about some real-life examples. One of them is a study that started a couple of years ago. This is a study that I'm a co-investigator on, and you can look up there with the web link for more information. It's called the CHOICE study, and it stands for Choosing Options for Insomnia and Cancer Effectively. And I wanted to give you some details about this study because it was something that we started with a group of patient advisors that had been involved in other research studies that we had going on, and they were involved in deciding which 2 treatments we were going to compare, which it is a randomized controlled trial of cognitive behavior therapy versus acupuncture for the treatment of insomnia in cancer patients. And it was actually the patients themselves that told us that we said we want to do another project, what area is important to you? And so they identified that sleep was an area that was important to them. So we said, okay, what kind of interventions are you interested in that maybe you don't know enough about? And they said for sure they did not want medication-based interventions. They said, we have had enough, we take enough pills, we want non-medication-based interventions. So we went off and said, okay, well, what are some of the best kind of non-medication-based interventions out there for insomnia? Which ones have the most evidence? Which ones don't have as much evidence? And we concluded that we actually came back to the patient advisory group with a list, and so we had a discussion at that point, like, which of these would you be interested in? And so it was really a collaboration between us bringing forward the scientific part, them bringing forward the lived experience. So we decided on comparing the cognitive behavior therapy via, and also comparing it to acupuncture, and we were able to come up with a solid scientific rationale for why we wanted to do that. But the patients were also very important in helping us choose our outcomes. We brought, from our perspective, what we knew we could also measure as it relates to sleep. One of them being patient-reported fatigue. So we had the patients review our outcome measures that we had selected from the literature, and they actually said, well, and one of them they didn't like at all. They said that it didn't capture mental fatigue. And that was something that they felt was really, really important. It wasn't necessarily physical fatigue. It was really just feeling like, mentally I'm not there. So we went back and we revised our methods in order to include a better measure of cancer-related fatigue. So I wanted to share that example just to give you an idea of how patients can be involved from the very, very beginning in determining the comparative groups that you're looking at. If you're designing an intervention study, they can help you with that. And then also having them identify priority areas, so you can then go and look at what might be available for patient-reported outcome measures that have solid validity, and then they can also evaluate those patient-reported outcomes to make sure that, yes, they feel like those are going to adequately do the job of assessing the constructs or the areas of their life that they deem to be important. Like I said, that study's just wrapping up right now. But another study that we have just starting is called the PROM study, and this is Priorities for Improving Experience in Young Adult Cancer Survivors. And again, this was a study that started at least a year and a half ago, where we've been collaborating with Young Adult Cancer Canada to identify these priorities for improving experience. So, it started a lot with discussion. I didn't come in with a lot of pre-existing ideas or something that I wanted to measure. I knew I wanted to do research in this area, but I said, okay, well, what are the biggest questions that you see working with this particular group? And with that, they have, again, helped identify the research questions. They have also evaluated the assessment measures, making sure that, yes, they will actually capture the constructs that we want to evaluate. So the key messages here with the real-life examples is that patient engagement piece really needs to come first, because that is going to influence where you go, what directions you choose, and it's also going to make your search for patient-reported outcome measures a lot more efficient. So once the patient population in your group has identified, okay, we want to study this particular outcome, how do you evaluate the variety of patient-reported outcome measures that might already exist for that? Let's say, for example, it's pain. Well, I can tell you there are hundreds of pain measures out there. So which one do you choose? Which one is the best? So before you do anything, though, you should understand the concepts underlying any patient-reported outcome measure. So pain in what population? How is it experienced? And how is it meaningful and noticed by the patients in the population of interest? You should also know how that particular symptom, if it's pain, how does that relate to the health decisions that the study is designed to inform? And you want to know for each of the patient-reported outcome measures, how they were developed, and also how patients were involved in the development of those patient-reported outcome measures. So this is a study that is just recently published by Wearing et al., and it's exactly talking about patient involvement in the development of patient-reported outcome measures. So they reviewed a total of 189 studies. These studies were describing the development of 193 patient-reported outcome measures. Patients were mostly involved in the item development. So this would be actually constructing the questions that would be included in the patient-reported outcome measure. They were also involved more than half of the time in comprehensibility. So is it worded correctly? Is it easily understood by a wide variety of individuals? And then, in much fewer cases were they actually involved in determining the outcomes. So this is a bit I think this is changing, but you still need to be aware that right now, in 25.9% of the patient-reported outcome measures that they studied, in the development studies there was no patients involved. So at least in a quarter of these studies, patients were involved. So, you know, if in the validation study you're looking at, it doesn't mention how patients were involved, if you have another measure that you're considering, that would be a justification for choosing one that has patients involved versus maybe one that doesn't have patients involved. So this is a little bit technical, and but these are going to be the areas that when you actually come across a validation paper for a patient-reported outcome measure, these are words that you're going to be confronted with. So these are things like content validity, construct validity, reliability, responsiveness to change over time, and then also there's going to be some sort of indication of how to interpret the scores. And this means that they're also going to need to talk about you know, whether or not these score changes are meaningful in the population of interest, you know, considering, you know, subgroups, and these might be things like males versus females. So content validity, this is generally referring to whether or not the instrument measures what it's supposed to measure. So this is where the relevance of the assessment instrument is evaluated, whether it's relevant to the construct being measured. And so what happens typically is the tool is created by experts, and then it's reviewed by users to ensure the face validity. So that's one of the ways that it's done, but not really necessarily the best way that it's done. So more and more now they're actually including patients in creating the tool and also reviewing the tool. But then there's construct validity, and this is defined as that there's evidence between the relationships and domains and items concerning relationships that should exist with other measures. So construct validity is broken down into convergent, divergent, and known groups validity. So basically, convergent validity is if I'm making a measure of pain, it should relate to an already established measure of you know, a similar construct. So pain and disability, you know, maybe something like that. I've got an example here of hopelessness and depression. Now, those are constructs that theoretically should be related to each other. So you want to make sure that your measure that you're using has good convergent validity. Also, you need to make sure that it has good divergent validity, so it's not related to other constructs that it shouldn't be related to. For example, if we're using depression here, depression should not be related to life satisfaction. And lastly, it's known groups validity. So this is important because it highlights that there's a difference between the group that you're actually studying, and the group that you're studying will perform differently than a different group. So the instrument should be able to differentiate between people who are, you know, if we're using the example of depression, depressed and not depressed people. And then reliability here, and this, I know there's a lot of words on this slide, but I wanted to make sure that people have this in order to reference it. But basically, you know, you can have reliability, but it doesn't necessarily mean that it's valid, right? So you can have a measure that has test-retest reliability, internal consistency, but it doesn't mean that it actually has any meaning or validity to the population that you're trying to understand a little bit better. So validity would be, you know, the biggest thing, but then it also needs to be reliable. So when I talk about reliability, I'm saying that it needs to be reproducible and it needs to provide consistent estimates of a true treatment effect. So this is more kind of psychometric stuff that would be reported in the paper, that it needs to have test-retest reliability. And so it's basically saying, okay, if I test this patient at, you know, baseline, and I test them again at, you know, 2 weeks or a month, depending on the particular symptom, you'd want to make sure that it doesn't change, right? So if we're talking about intelligence or something like that, we test them 1 month, their intelligence really shouldn't change if nothing has happened between baseline and 1 month. So that would have good test-retest reliability. If you want to have a measure that is able to be repeated among a shorter period of time, so maybe it's weekly, you want to make sure that the measure is reliable over the shorter period of time, so it can be administered over briefer periods. And then internal consistency is just basically whether or not the individual items deliver consistent scores and are related to each other. So this is determined statistically with a value called a convex alpha. And then there's also interviewer reliability, and this is just the determination of any changes in the results when the instrument is administered by 2 or more interviewers. And this may or may not be the case for your particular measure because it might be self-administered, but it's generally measured by a correlation. So now the instrument also needs to be responsive to change. Especially if you're evaluating an intervention, if you're evaluating the disease process over time. So it should be able to detect changes in the specific outcomes. And I think that this is an important thing that a lot of papers miss, is that even if your results are statistically significant, it doesn't mean that they have any clinical relevance or that it actually has a clinically meaningful difference in the patient population. So I give an example here of the Insomnia Severity Index. That actually has clinical cutoffs for severity of insomnia. So you can tell whether or not the person has moved between groups of, having severe insomnia, moderate insomnia, low insomnia, or no insomnia at all. It also has established what's called a minimally important change value, which means that this change of 8.2 points has actually been demonstrated to represent a clinically meaningful change for patients. That's really important if you're talking about an intervention, is to have the measure be able to say not only is it statistically significant, it also is clinically meaningful for the patients. So where can I find a PROM? Now I wanted to make you aware that there is a group in the United States called PROMIS, and it's a group of researchers that are putting together a whole bunch of patient-reported outcome measures, and they're using very, very good validity. So again, you shouldn't necessarily think that or try and recreate the wheel. If it's already out there being done in a valid way, feel free to use some of these other measures. So I wanted to show you this web page here where you can actually search for available patient-reported outcome measures. So hopefully everybody can see this. So if we go here, this is the main page. And so you can see there's lots of information, why use PROMIS. But then we can also go here to search and view measures. So hopefully this will work. We're trying this out for the first time. So you can see here that you can search by age. So I'm going to say, all right, we're going to do adults. And then we're going to do, I want to know about, physical health. And here you've got various aspects of physical health, so dyspnea, pain, fatigue, sleep, right? So,
You can recall all that.
oh, okay. Sorry, we're trying this out for the first time here. So, oh, is that what people see?
Now they see it.
Oh, they see that. Okay. Sorry about this here. We're going to work it out. We've got a little bit of a lag here, so if you guys don't see this yet, it's coming up. So,
I don't know if you can see it if you use it.
Can you guys give us an indicator here whether you can follow along with what I'm doing with the search and view measures? Maybe indicate, oh, we've got 1 yes. Okay, 2 yes. Okay, so they can see what I'm doing.
That's right now.
Okay, 3 yeses. So, it's not going to let me move down.
No, it's going to see what you're doing.
Okay.
I don't think so.
Okay.
You can try it one more time.
All right. I'm trying this one more time here. Yeah, it's not letting me. Sorry, we're trying this out for the first time here to be able to kind of work with the web page. But basically, it's not difficult for any of you to go to this page here. Even if you Google PROMIS, that's P-R-O-M-I-S, and here you've got the search and view measures, and it'll actually bring up measures for you to be able to select from. Okay, it's now letting me go to search.
So we're doing another page?
Yep. So we'll go to the next one. Hopefully you'll be able to check that out on your own. It's a really, really great resource. Okay, so that's where that is. So it's PROMIS. It's the Patient-Reported Outcomes Measurement Information System. This is their main page, and then this is where you can go to search and view the measures, and it provides the instructions on how to do that as well. So the next one is there's an actual patient-reported outcomes measurement group in the UK, and we'll pull up that page for you here to show you what that looks like. Waiting for the page to load. Here we go. So this was actually very helpful, especially if you're looking for larger reviews of already what's been out there. So if we click on here, the reports and publications from January 2009, you'll see all of the patient-reported outcomes that have been reviewed in a variety of different areas. So chronic kidney disease, heart failure, asthma, epilepsy. So there's also gynecological procedures. So if you click on this for chronic kidney disease, it should bring up this paper here, where it's going to review a lot of the measures here that have already been published here. So the generic PROMs, the preference-based PROMs. So again, it's a nice summary. So again, it's already there. You don't need to go searching for it on your own if you can go to one of these pages that has already done all the work for you. Okay. All right. Now if we go to the next page, this is probably the more kind of traditional way of looking at what's already been published in the area of patient-reported outcomes in your particular group. Is you're going to PubMed, you're looking through systematic reviews, and seeing what other individuals have used. I like limiting my search initially to try and be efficient to systematic reviews, because again, if we can find one that is recent and has gone through the reliability and validity of various measures, that can make your job a lot easier. I just put a couple of examples here for you to see, just to note, there's definitely a lot of good reviews out there on patient-reported outcomes. This first one is recent, and that's fatigue as a patient-reported outcome. And then also one that's a little bit more specific, and that would be quality of life in individuals with lupus. Now, I think before I go on, I'll take a couple of questions, if there are any. I've got Eva here beside me, so she's going to let me know. Any questions? I can answer any that are maybe specific to the research that you're thinking about, whether you have any questions about patient-reported outcomes that you're thinking about using, maybe that you're currently using, engaging patients in how to evaluate or help you identify some of the areas where you want to look for patient-reported outcomes, anything like that.
I don't see anybody typing, so I'm looking
Any questions?
at
Okay. Well, if there are no questions, we're happy to answer any that might come up later in the process of looking through the slides, and maybe you have questions about where to find or how to evaluate particular PROMs. We can definitely help you, and I'm available to answer questions afterwards. So I think that the next date for the clinician-led research grant, I'm going to pass this over to Eva.
Thank you, Sheila, for this wonderful presentation. That was absolutely great, and I guess a lot of people will think about it and might come back to you when they have questions. I just want to announce our next webinar, which is an additional webinar, which is not part of our training program, but we added an additional webinar about the clinician-led research grant. So if you're interested in this grant as a health professional, please join this webinar. We will answer your questions, and we will give you some more information what this grant is about. And then we have our next regular webinar on big data on March 23rd, same time, same place. So sign up on Eventbrite, and you will receive the link in advance. If there are no further questions, then I would like to thank you all for joining this webinar, and please share your evaluations and your thoughts with us. We will share a SurveyMonkey link with you with the presentation slides as well. And the webinar will become available on our website. Thank you all. And we will stick around for a little bit, so if you have any questions, please feel free to share them in the chat box, and Sheila Garland is here as well, so we might be able to answer them. Thank you. Have a wonderful afternoon.